I'm Charlie, and on a Tuesday afternoon, I'm Dr. Dribble. And saliva control is something that I've been very interested in for virtually the whole of the time as a consultant. As Dan said, I've been a consultant now for about 22 years in the field of childhood disability. And my old senior speech and language therapist colleague and I set up a saliva control clinic in the early 2000s because it really hit us hard that we were seeing children in a variety of clinics, whether it be my physical neurodisability clinic or Helen with her sort of feeding and swallowing clinic, that families were feeding back to us time and time again about how much of a physical and psychological problem there was associated with children who had problems with saliva control. And as time has rolled on and as we have developed our knowledge in the area, I'm still very much struck that as a society, we're pretty good with coping with disabled children. To be in a wheelchair is relatively normal and exceptionally well tolerated by the wider population now. And even if you've got seizures, you're having a seizure and you're a child, and the wider society can cope with it. But as soon as you put a child a bib around them or a large tea towel and they start smelling of stale saliva, then society as a whole is still absolutely horrific in their way that they cope and deal and treat with children with saliva control difficulties. So that's the main reason why I've developed such an interest in this area. And as I said, for the last 20 years plus, we've been running a specific service in saliva control difficulties. So I'm just trying to move on, click away. So this all sort of came to a head predominantly. I was chair and led up the NICE cerebral palsy guideline that we published just over 3 years ago now. And we looked at a variety of, we were allowed to ask a number of specific questions about cerebral palsy. One thing we weren't allowed to ask about was the problems of movement and posture, because they felt that NICE felt that had been covered already in the previous spasticity guideline. So we really focused very clearly on the comorbid challenges when we were thinking about the management. So we thought about the clinical comorbidities, chest health, gut health, developmental issues of walking, of communication, mental health, which is really important, but also these challenges of functional issues. And within the managing functional issues, we focused very much on the 4 areas of eating, drinking and swallowing, pain, discomfort, sleep disturbance, and saliva control. So saliva control was an area that we had 2 questions out of 20 that we were allowed to deep dive to look at the evidence base on how you assess and how you manage children with neurodisability and saliva control difficulties. So that's the basis of where we are. As I said, I will go over much of this rapidly because this is bread and butter to you lot. But when I'm talking with paediatricians in particular, I need to spend a relatively long time explaining what is normal before I start thinking about what is abnormal. So I'm going to spend a little time talking about saliva control and the problems that I deal with in the paediatric population, the young adult population, and also the solution in what we do with regards to how we assess and how we consider we're going to help the child reduce their sialorrhoea. So saliva, we, as you are very aware, produce between ½ litre and 1 litre of saliva a day. That's something that always shocks the parents when you talk to it. They don't think that this is that we are creating so much during the daytime. Again, as we are aware, it's under the autonomic nervous system as control, and it's parasympathetic on the whole in terms of the drive. You lot, you see it on a regular basis. Us lot, I look at it in an ultrasound scan, so I have an awareness of the salivary glands, but they are big. They are not small things. And we have the submaxillary ones and we have the parotid ones. And the thick mucus secretions at rest are predominantly created by your submandibular glands. And then when the stimulation comes from eating and drinking and oral activity, you get the more watery serous secretions created by the parotid. And that is a terrible picture showing the areas on the parotid side of things. You've got your parotid, and then underneath the angle of the jaw, you've got your submandibular, and then more anteriorly, you've got your sublingual. And I, though I look at them on a weekly basis with my ultrasound scan, I'm always amazed at quite how large they are, particularly when you've not got your normal function of talking, chewing and swallowing. Why do we have saliva? We all know again that they're really important in keeping your mouth healthy, and that it's there to try and, in a bacteriostatic viewpoint, as well as facilitating eating and initiating carbohydrate digestion. So there are specific reasons why we have saliva. So to switch it off altogether isn't necessarily the right thing, because there's an awful lot that you need, particularly in oral hygiene, that's really, really important with standard saliva. We swallow about once a minute when we're awake. As an adult, we swallow about 600 times a day. And as we stated, the vast majority of the times when we're awake. When you're thinking about abnormality, as I said, I'm Dr. Dribble. When you're looking at normal versus abnormal developmental, there's very little out there on looking at population-based norms. But on the whole, from a developmental paediatric background, it's relatively normal to have anterior sialorrhoea or coming out the front of the mouth until around 15 to 18 months. So really, you shouldn't worry too much about drooling and dribbling up until that point, unless you've got problems with posterior sialorrhoea and it going down and causing aspiration. Drooling is still relatively common before the age of 3 years, particularly when a child is eating and drinking. So it's really at that sort of point that from a developmental viewpoint, you start getting more interested in how we should intervene, how we should facilitate a child with their saliva control. So what happens when it doesn't work? What sort of populations do I see? And initially, what are the causes of saliva loss? As a neurologist, I obviously start off thinking about neurological problems. And there are some really rare primary hypersecretion problematical challenges. I don't see too many children that smoke, but I do see an awful lot of children with gastroesophageal reflux. But complex temporal lobe epilepsy is a challenge that we see with primary hypersecretion, i.e. creating too much saliva. And also, as we'll see later on, many of the medications that we use do cause a problem, particularly those who we use in children with a dystonic or a fluctuating motor disorder. So really, the main population that I see are children that have secondary causes of drooling. They don't have any hypersecretion, but they cannot swallow properly. And a lot of the problems come from postural problems. Children that have real difficulty in keeping their head out, and the saliva pools underneath the tongue and just comes straight out the front. So they have real problems with oral motor disorders, the lip closure is a problem, problems of intra-oral pressure, and problems associated with total infrequency of saliva. And as I said, that hypersalivation problem is really complicated in my world with children with epileptic encephalopathy and children with cerebral palsy on anticonvulsants, particularly the benzodiazepines. And in your world in particular, again, the problems of tooth eruption, dental caries, and ENT problems, problems of not necessarily hypersalivation, but secretion problems coming from the upper airway. So, as I've stated and started talking about, esophageal disorders are also a major problem. So, gastroesophageal reflux is a very common problem in children with cerebral palsy. Dependent upon the severity of cerebral palsy, it can be anywhere between 75% and 97% of the children have a problem of chemical inflammatory hypersalivation because of gastroesophageal reflux. I also see an awful lot of children, particularly with obstructive problems from nasogastric tubes. Now, nasogastric tubes, as far as I'm concerned, are shocking and really needs to be there only temporarily and moved on rapidly downstream to a gastrostomy tube placement, because they cause all sorts of problems with the lower esophagus in particular, and problems with stimulation of the vagal afferent fibers and direct stimulation leading to hypersalivation. So overall, what is the prevalence of saliva control difficulties? My biggest population, and we'll come to our metrics downstream in a wee bit, from the population over a 5-year period that we've seen at the Evelina in our saliva control clinic. But overall in cerebral palsy, somewhere between 10% and 37% of children have got a problem with anterior predominantly, but also posterior sialorrhoea. And the biggest study was done by Parks et al. In 2010 in terms of looking at epidemiological cross-sectional study, which set it around 22%. Now, I don't know how many of you are aware of something that we call the gross motor functional classification system when you're talking about cerebral palsy, but it's a really children-like chocolate, simple way of talking about your functional challenge when it comes to your movement. So it's a stepwise scale. So children with GMFCS level 1 are fully independent walkers, whereas children in GMFCS level 5 are totally dependent on others for any form of mobility. Levels 1, 2, and 3 are independent walkers, but they get more and more challenged in their walking. And level 4 are generally children who are in wheelchairs who either self-propel or have powered mobility. And as you can see, the big jump is between that powered mobility or self-propelled group and those that are completely non-ambulant. And those are children who've got much less control of their oral motor function. They're children on the whole that are gastrostomy fed. They're children on the whole who have poor postural control of their head. So saliva control difficulties in that GMFCS level 5 population or non-ambulant population are markedly prevalent. Even in that population, however, the problems with saliva control do tend to decrease over time, particularly decreased post-secondary eruption of dentition in the young adolescent population. And that's why, when you'll come and see on our sort of algorithm of treatment, we tend to think about more long-term interventional treatment options such as surgery in the post-adolescent population as being the appropriate thing. What are the consequences? So this is where I came from when we set up the saliva control difficulties. As I said, there are a variety of medical and social challenges for the child and their family with regards to drooling and dribbling and anterior sialorrhoea. So at the extreme of the situation from the medical viewpoint, I was seeing children who had gone into pre-renal failure from dehydration. I was being referred children from throughout the United Kingdom who had gone into renal failure with the level of saliva loss. But more just as problematical in many ways, the skin breakdown, the irritation that they have, real problems associated with seizure control because of loss of the homeostatic situation, but also problems with seizure control, not least on many of the medications that we use. And again, we'll come to that in a wee bit. But it's this social quality of life challenge that a number of studies have picked up on with a degree of social isolation for the child and the family, let alone if they use augmented communication equipment, you can fuse. I mean, you don't want to be dribbling all over your computer and damage to books, damage to schoolwork. So there's real problems associated with both social and medical problems. So when we looked at the NICE guidelines, we then focused very much on, initially on assessment. There are a whole variety of research measures which really are of very little practical use in a clinical situation. So there are these elements of chewing on gauze for a minute, using a bib, weighing bibs, using a chin cup, placing it under your chin, trying and strapping it in there and weighing. They're all fairly useless. But actually what really, really helps us on the whole are the development of parent and teacher rating scales. So quantifying qualitative problems that the child and the family have. And these are the two that we use in clinical practice. So there's the Drooling Impact Scale set out in Reed et al. In 2009, and the Drooling Rating Scale, which is now the modified Drooling Rating Scale of Thomas Stonell and Greenberg. The Drooling Impact Scale is a score out of 100. There are 10 factors that are scored in between 1 and 10 in terms of the impact in each area of qualitative challenge. So we think about the frequency of saliva loss, the severity, the numbers of bibs or clothing changes per day. 1, 10 is the maximum. But actually one thing that we sort of modify this, and we think and talk to the families as well on a bibometer scale. And if a child is getting through 20, 30, 40 bibs a day, that's a really, really profound anterior sialorrhoea loss. You ask about the frequency of skin irritation, the frequency of wiping saliva away from the chin and the mouth, how embarrassed that child is by the saliva and the saliva loss, the frequency of wiping saliva off household objects, and then the two critical ones on how much of a problem is it for the child, what's the impact to quality of life, and what's the impact to quality of life on the family. And you get a score out of 100, and you do that pre and post any intervention. And we do that regularly every single time that we see them every 3 to 6 months in clinic as well. We also do the Drooling Rating Scale, which is terribly simple. That's just an overall scale of severity and frequency, severity out of 5, and frequency out of 4. And again, it's just a quantification of the qualitative problems for that child. So we assess, and then from a neurological viewpoint, we think about things in general. As I said, we do that bibometer, how much soaking equipment. We talk about equipment problems, how much soaking of clothes. But we also think about other neurological clinical factors, other neurodevelopmental clinical factors, problems with posture, problems with communication, problems with oral health and dentition, and the ENT side of things, obviously. So we look at physically at their head and trunk position, we look at their mouth, tongue, and jaw movements, we think about the other aspects of neurology and their movement disorder, and the speech and language therapy team that I work with will look and think carefully about the safety of swallow for that individual child. So that takes us away from the assessment and into the management, which is the next question on the NICE cerebral palsy guidelines. So this is the summation, and I would recommend you go and have a look at this if you've not looked at it before, because the NICE pathways are really, really good. If you're stuck in clinic and you haven't got an idea, you can click into the word search of NICE on their main website, saliva control, and it'll come straight up to this and will give you a clear algorithmic viewpoint of how you should manage things. So once you've assessed the saliva control, you're then considering a variety of anticholinergic medications as far as the NICE guidelines. We'll go into a little bit more detail on our direct algorithm within our clinic in a little bit, but it's really giving you the choice of glycopyrronium bromide, which is licensed for use, or transdermal hyoscine hydrochloride or a hyoscine patch, which is unlicensed for use, or trihexyphenidyl, which is a antidystonic medication that is an anticholinergic as well. So we tend to use that to try and get a bit of a double whammy in children with a dystonic or dyskinetic movement disorder. NICE has also, a month after we did the cerebral palsy guidelines, come up with its own evidence summary on oral glycopyrronium bromide. So again, you can go and have a look at that. That's ES5. So once you've assessed, you then think about which child to use. If that doesn't work, you can then consider referring on to specialist services who could consider whether that's an ENT service or a neurodisability service who've got experience in the use of targeted botulinum toxin injections to try and reduce the frequency and severity of saliva control. And I'll give you our own background with regards to that as we go through the protocols. This is the algorithm that we actually adopted within the NICE guidelines, and it comes from this seminal paper by Fairhurst and Cockerill in Archives of Disability in Childhood on the management of drooling in children. And this goes through what is the sort of sieve of treatment options, ending up with surgical on that side. So we looked at a 5-year population of children referred in to our saliva control clinic. And over that period of time, from May 2013 to December 2018, we had just under 425 new patients, of which the majority, almost half, were children with a severe cerebral palsy. The main other areas that we had were children with Worcester drought, or almost like a bulbar, a pseudobulbar palsy associated with almost a cerebral palsy of your bulbar function. A next large population of children with autism, Angelman, and behavioural disorders, a really challenging group for us to manage. A variety of genetic and syndromic problems like Rett syndrome, Lesch-Nyhan syndrome, again, children with challenging difficulties around the oromotor area, children with poor oromotor closure, and a lot of children with just an isolated epileptic encephalopathy. So our approach is to go through the protocol. So initially, if it's appropriate, and you'll see how rare it is appropriate, you can consider oromotor exercises. Now, children need to be able to work closely with a speech and language therapist for 10 to 15 minutes every single day in a one-to-one situation with a clear focus, and then go and work on it for 2 hours by themselves. So there is a very small population within that 420 that we have come across that we've been able to go and say, go and work on a clear oromotor exercise program. There is no evidence for vibration therapy. There is no evidence for icing. But as I said, there is some evidence for specific myofunctional therapies, such as the Swallow Right program. And this is a sort of modification of the Swallow Right program, which is trying to get a child to learn where the end of the tongue is and to be able to close their lips and to move the saliva back through the oromotor cavity and swallow. So it's really re-educating and teaching what should be an automatic thing for the child. So it's very rare that we get that. And it's really a child with a good developmental age. They've got to be able to be cognitively able. They've got to be able to imitate the oral movements that are shown to them. And they've got to be compliant with a regular program. And even then, out of the 425, 423, we only had 10 children that we could do a myofunctional therapy. And in all these slides, what you'll see is that drooling impact scale out of 100 before intervention, drooling impact scale out of 100 afterwards, and also the drooling rating scale changes over a period of time. And just because I'm really interested, because I think quality of life for the child and the family is vitally important, you'll also have the quality of life at the end. So for all these treatment options, we'll give you the breakdown. So you've improved it by a factor of 11.5. So as far as NICE is concerned, that's a good minimum clinical importance and difference. So they say, okay, think about it, because you're actually improving it, that you're improving the DIS by more than 10, which is outside the range of chance. So the next one to consider is behavioural treatment. So again, that's an awful lot of retraining, re-educating the child. And again, the results of those are better if the child is more cognitively able and milder drooling. And that's when you can get the psychologist involved, which we have done on a relatively regular viewpoint. We tend to do it together with the myofunctional therapy program, so we haven't actually got a breakdown on that. The most simple things that you need to talk with the children and family, however, are real conservative measures, such as getting them to dab the saliva away rather than wiping. Because if you wipe across the mouth, you will increase the saliva loss. Whereas if you get them to kiss an element, it doesn't stimulate the saliva loss as much. Also, much more socially acceptable for many children and young people, particularly if they are more cognitively able and in mainstream education, is using toweling wristbands rather than bandanas or bibs. And they can roll and they can dab the wipe and change the toweling wristbands on a regular basis. So they're simple, conservative ways of dealing with it. Also, the avoidance of triggers such as sweet foods, such as chocolate. Also have an awareness that if they have an upper respiratory tract infection, if they've got an ERT, it's going to be more problematical for them. There's an area of interest on alternative therapies such as acupuncture to the tongue and banding and taping. Not clear evidence base, but it's an area of interest and one that we need to have an awareness of as well. My first job back in the mid-1990s as consultant was at Chailey Heritage, and at Chailey Heritage we developed a saliva control interest because we had a fantastic dentist who was really good at developing intra-oral devices. Now, intra-oral devices they have a limited function, but they're really good in some children. And again, what they're trying to do is stimulate a normal swallow. So they are a modified brace with a variety of ridge and bumps over the top of the palate and then a loop at the back. And so what it encourages the child is to run the tongue back along the ridges and bumps, and then it stimulates the swallow when they hit the loop. Anecdotal reports of them being useful. Still use it at Chailey Heritage. We haven't got a dental department here that are terribly interested in developing, but you know, just to give you the full element of all treatments and approaches to management, it's something that you can consider. So that leads me to my medical world and the approaches to management. Now, historically, there was a lot of look on anti-reflux medications for the treatment of saliva loss. And as you'll see and remember from what we were saying in terms of the problems from a neurological and the problems from stimulation of the oromotor cavity, actually untreated gastroesophageal reflux will increase your saliva control. So you need to think about these things, not just on hitting it straight on, but if there is a causation, if there is an ENT causation, if they've got problems associated with upper airway, and I deal an awful lot with antihistamines, and in particular the use of spray anticholinergics and the use of fluticasone nasal spray, if there's an awful lot of congestion in the upper airways, that's also leading to a real problem with saliva loss and secretion challenges. The anticholinergics, as I said, we talk about in great detail in our paper in 2011. You've got those pre-anesthetic agents, whether it's hyoscine, atropine. Now, atropine drops are fairly widely used in adults and seem to be equally efficacious. And the one that we've got the greatest experience of is glycopyrronium bromide, but also the elements of antidystonic medications, the use of trihexyphenidyl, and as I said, using the inhaled agent, inhaled anticholinergic agent of Atrovent or ipratropium bromide, which is a anti-asthma medication, which main side effect is drying up oral secretions. And we use that in our own treatment. And these, again, both in the NICE guidelines, also in that article from 2011 from Helen and me, give you dosage of glycopyrronium bromide, trihexyphenidyl, and ipratropium bromide. And as I said, Salinar is now the licensed formulation of glycopyrronium bromide in the United Kingdom. There are others coming out, and they will give you clear guidance as to the dosing table of that. The problems that we see, funnily enough, with anticholinergic medications are anticholinergic side effects. So there is irritability, there's sedation. Main problems that we tend to see, however, are constipation and urinary retention. In an extreme viewpoint, problems with seizure control. And also, if you use them for a long time, particularly hyoscine patches, a loss of effect. So looking at our initial appointment of those 423 patients that are referred into us as the tertiary centre for saliva control difficulties in childhood, 157 of our patients had already had a prior use of anticholinergic, of which the majority, the vast majority, had used hyoscine patches. Now, the main side effects that we've seen in that population were a skin reaction, a markedly problematical skin reaction with hyoscine patches, and a real challenge of worsening of seizures. So much so that some children had never had a seizure until they were started to be treated with a hyoscine patch. And then as soon as the child was stopped being treated with a hyoscine patch, the seizures went away. With regards to our hypersialorrhoea and epilepsy population, there's just a quick thing down there at the bottom. Clobazam and clonazepam are medicines that really switch the taps on and you have to have an awareness of. Glycopyrronium bromide, in terms of side effects, constipation is the main one, but it's much less problematical, the side effect profile of glycopyrronium in comparison to hyoscine. And these were the children that we used in terms of thinking about outcomes. So we initiated glycopyrronium bromide in some, we initiated trihexyphenidyl in some, and we initiated ipratropium bromide as an inhaled agent. And they may well be summative, but these are before that child was treated with that treatment option. They might be on something else as well. And then in review, at around 3 months afterwards. So you can see on the whole, the oral medications improve the drooling impact scale by around a factor of -20. So about twice as good as the inhaled and also twice as good as the myofunctional therapy viewpoint. And again, they are improving the DRS at about double the amount as the inhaled or the myofascial training. So when that's not enough, you've got to think about botulinum toxin injections. You can think about it, okay? It's fairly widespread in its usage. There are clear international guidelines on how you should be doing it. It is the most potent neurotoxin known to man. I know the man who injects it across Kylie Minogue's bottom on a regular basis, happy in his job. So it's used for cellulite. I know the man who does it in Nicole Kidman's face on a regular basis. But it's far more useful in my world to reduce pain, discomfort, muscle spasms in muscles, and to reduce the amount of saliva production. You should be always contemplating using sedation. I have an increasing cohort of children that don't want me to use sedation because they don't like it. Dan and the rest of the ENT team are fantastic at facilitating and allowing me to join them on an ENT list and do this from time to time in the anaesthetic room in children with profound behavioural disabilities, so that autism population in particular, where you can't get near them with a needle. So sometimes you need to do it under general anaesthetic, but that's rare. To be honest, it's about 1 child a month that I'll do out of about 150, 200 a year. Always use ultrasound guidance, and I'll go through my technique. We use really low doses. We use Botox because it spreads less. Xeomin seem to be, so those are types of botulinum toxin type A. So Xeomin and Botox seem to have a relatively good safe. I have heard of problems, and I do not use Dysport because it tends to spread a little bit more. So safety is vitally important. My approach is single injection to each saliva gland and really, really low dose. And touch wood, and believe me, I'm touching wood, I have not had any problems associated with that. Other places have. That tends to be when you're doing multiple injections across the saliva glands and when you are doing much higher doses. I think safety is all important, so I keep it really, really low. And this is my approach. So this is one of my gorgeous young adults. So she's not wanted and doesn't need any sedation, but I mark up, I look with the ultrasound scan beforehand, see where the saliva glands are. I will put lidocaine cream over the site of where one parotid and both submandibular glands are, leave it on for an hour. I'll then get my ultrasound machine out again, and here we are. You can see that grey blob in the middle of anything, and it's normally about 3 or 4 centimeters across by about 2 or 3 centimeters deep. So always look and see, because you will find that some saliva glands are not where you expect them to be, and there is an awful lot of dodgy material in terms of nervous and blood supply there that you don't really want to be hitting. So have a little look, check where you're going, check whether you think, if you want to mark, if you're in theatres, you can use your ultrasound scan and watch. You can use that we go along the linear aspect of the probe so that you can see the needle going through and into the saliva gland. I tend to find that actually if you do it in an awake child, what you need to do is to gauge where you are with the ultrasound scan, then do the injection. Otherwise, you will be focusing on the needle, and that is when you can potentially go too deep. And I have got a colleague who's had a side effect associated with focusing on where the needle is rather than focusing on the child. So focusing on the ultrasound rather than the child and the needle. So that's the way that I do it, and that's the way that I've learned to do it. And then there's the parotid, which is about 1 centimeter deep, and it's about 1 centimeter in front of the tragus that I tend to go for, and I tend to get a good effect and a good benefit at that point. So then I'll go in clinically. It's about the size of a plum underneath the angle of the jaw. I put my, I can basically run up and down the corridor, because what I do is I will anchor myself with one finger at the angle of the jaw, and then I will leave 1 finger's worth of gap before I then anchor under the jaw with my other finger. I will then have, as you can see there, the syringe into my thenar eminence, and the child can move their head quite markedly, and I can still be comfortable that I've got that needle in the gland, and it's not causing any potential damage. Equally, when I get to the parotid, I will rest my hand on the edge of that individual's face, and they can again move, and the needle end does not move. But that's basically just because I've done a gazillion. So what are the problems with botulinum toxin injections? There is some evidence you can get thickened saliva, as you can with any anticholinergic. There is some evidence that if you go, particularly if you go high dose and you go multiple things, that you can lead to swallowing difficulties. As I said, touch base, I've never had any problem associated with that. And that's the real reason why we are concerned about spread. And I tend to stick to ones where I am comfortable that the botulinum toxin itself is manufactured in such a way that that is limited in potential. Over a period of time, there is some concern about lack of effect. Now, again, that was with very early botulinum toxin injections, where the 2 strands of the antitoxin were not terribly well manufactured. And you used to have little bits that used to break off and be very immunogenic. So you used to get antibody formations. There's some elements about the trauma of the procedure as well, but to be brutally honest, we haven't run into too much of the problems. I do come across an occasional bruise associated with it, but I tend to sort of either pretend to be Daddy Pig or sing Baby Shark, and most of the children look at me sympathetically and allow me to do it. It's not too traumatic. And this is our outcome within our population. So over that 5-year period, we did injections, we did 551 courses of injections in 186 different children, with an average change in the drooling impact scale of around 40, and an average change on the drooling rating scale and severity of 2, and frequency of 1.5. But a marked improvement in quality of life for the child and the family. As I said, we had minimal side effects over that period of time. One thing that's really that's out there in the literature is the risk of chest infections. You are dealing with a highly friable population. And so what I did is I looked at my population before I did the saliva injections, and I looked at the rate of chest infections, and I looked at the rate of chest infections afterwards. And it was markedly reduced post-botulinum toxin injections because the aspiration was less. However, if you want to look at lies and statistics, any sort of reported element of concern about botulinum toxin injections and chest infections afterwards takes no account of the risk of the population without a reduction in their saliva loss. So I would caution you that if you have people that come and say, well, you know, botulinum toxin injections, you're increasing the risk of saliva, they're not working from the basis that this is a population that regularly get chest infections. And if you don't manage it, they are more likely to get chest infections. So our population, in terms of length of benefit, on average, it was 6.38529 months actually, or up to 6.39 months. Though the range was anything between 1 month and 18 months. They were getting prolonged and protracted benefit in reduction in anterior and in particular posterior sialorrhoea. So that leads me on to your area. So I work very closely, as I said, with Ian, with Dan, on a consideration of surgical approaches. And we liaise with each other in terms of if they're referred patients and the medical side of things and the botulinum toxin hasn't been considered, they will refer to me. And equally, if I think this is a child who would do better with surgery, I will refer on from our saliva control clinic onto you in the ENT surgery. And there are a variety. I'm not going to teach my grandmother how to suck eggs. I know very little about this area, except to say that our ENT department at the Evelina rocks when it comes to this. It's predominantly duct ligation, duct transpositional surgery, but also removal of gland. The results can be variable, and there have been some meta-analyses on it. Again, the problem of less effectiveness for more severe cases, but there's no doubt that it does last longer in terms of its benefit with saliva control. And the meta-analysis in terms of looking at complications, these are the sort of areas that have been highlighted in terms of aspiration, problems of nerve damage, problems of localized edema, ranulae, or painful swellings associated particularly with duct ligation, and ongoing dental problems if it's done too widely. Our recommendation tends to be that unless we are at the end and we're not winning with anything, we rarely recommend it before puberty for the reasons that I talked about earlier, that things can often settle down once secondary dentition has erupted. So this is our surgical cohort of the children that have come through here, though Dan and Ian and everyone have done far more children than this over that period of time. But these were the ones that we saw, we'd referred on for surgery and came back to us post-surgery. So you'll see that in terms of changes of drooling impact scale, on the whole, it's about the same as botulinum toxin. So it's just over 40 rather than just under 40, which is the botulinum toxin. And again, the drooling rating scale is just a little bit less, and the drooling frequency scale is a little bit more in terms of benefit, and a marked improvement in quality of life for the child and the family. So if you're looking at them all and comparing them all as a whole, that's your comparison endpoint summary slide. We're almost getting to the end of the presentation, guys, I promise you. So as I said, oral medication -20, botulinum toxin and surgery -40. Myofunctional therapy and inhaled epitropium about -10, -12. And then this is a slide that we looked with regards to thinking about the drooling impact scale difference and the variety of interventions. Just again, to give you some sort of pictorial differentiation as to what's going on with a variety of treatments pre and post intervention. So in conclusion, EUR, guys, last slide. There is no point thinking about managing drooling without a speech and language therapist involved. Really, in an ideal world, it would be with someone who's got an interest from a medical viewpoint and you within the ENT service, but we tend to do this side by side. I've got a very clear awareness of how you manage it in the ENT within our ENT team, and equally I think they've got a pretty good one-on-one. So we work side by side. But you're never going to win in anything in my world, particularly in the world of neurology, if you don't do it with your therapists who've got much clearer idea about swallowing difficulties and challenges. Okay, your treatment options should be based on your clinical judgment as a surgeon or me as a medic, following the published and agreed algorithms within the NICE guidelines. Okay, and really the most crucial thing is to improve that quality of life for that child and their family. Yeah.
Now, of course, that's a fantastic viewpoint with regards to the complex children. I guess also, I don't know how much of a view you have with regards to the less complex children that we sometimes see in ENT clinics, in terms of your advice with regards to the developmentally normal preschool or peri-school child. If you have any advice with regards to them, Charlie, that you wish to pass on?
Absolutely. From my viewpoint, you start the algorithms. I rarely go down to the level of botulinum toxin with that population group, but I will talk about I'll talk about developmental normality. So everything in life is a bell-shaped curve. So some of those children may have a very mild Worcester drought. So they may have a very mild bulbar challenge, and they will come at you with a variety of very mild learning difficulties, a variety of problems of their chew and swallow as well. So it's where that normality is. But we do see children who are developmentally normal otherwise and have an isolated sialorrhoea. So about 15 of our 423 patients are in that population, so even we will see that. So the first thing is educating the parents. The next is thinking about the conservative measures and thinking about it. The next, and particularly, is looking at that quality of life aspect. And if there are real difficulties for that child in a social situation or in school, we will consider oral medication in particular. So we do some glycopyrronium bromide. If that child, as stated, is over 5 and is developmentally okay and can manage, we will work with a local speech and language therapist in using a myofunctional therapy program to try and give them the awareness and learn, so they can learn about how to swallow rather than it being innate. So the most simple things, so your conservative measures and your early points of treatment options. Many children will send to school with an Atrovent inhaler because actually, you know what, in a classroom of 35 children, about 4 or 5 of them are going to have an inhaler, which are kept by the teacher for their asthma. So actually, if you can give a child an inhaler that may give them some benefit for a few hours in the school, then it's entirely appropriate. So that's a nice little thing to sort of try and nurture and nuddle with, because the children won't be looking at them in a peculiar way. It's very socially norm for the use of an inhaler and a puffer in a school environment.
And do you think it's reasonable for non-paediatricians to prescribe that if they think it's appropriate after a period of waiting and so on?
I think it's entirely appropriate for a GP to do that. I think you lot know far more about what goes on in the saliva world than I do. I've just learned the ages. I think it's utterly appropriate. It's clear, it's there, it's in the algorithm, it's in the NICE guidelines. It's very simple to use and terribly easy. And it's
Thank you, Charlie.
So the GPs love you because it's the cheapest thing, cheapest medication known to man. Whereas glycopyrronium bromide, they will hate you for because it's really expensive.
Botox doesn't work all the time. Why do you think that is?
It's very rare, I have to say, out of our pretty extensive experience, that it doesn't work. I think there are several things, and I've mulled over this when I sit in the sort of European consensus working groups on this. Several things. If you're using it too often, it may well not work because your gland's not recovered. If you are, you've got to make sure you're in the right place. So you've got to have confidence that you're in the right place. You might just not be getting it. You might not be hitting it. You might not have knowledge that you're not hitting it. There is some concern about antibody formation. There is also some concern about botulinum toxin needs to be maintained in a refrigerated environment. And if part of your delivery network breaks down in a refrigerated situation, it's going to denature the botulinum toxin. So, you know, we have had the odd occasional child where we think that should have worked. It's worked in the past, hasn't worked this time. What do? We always tend to give them a second go. We don't go, oh, it didn't work, we're not going to do it again. We always give it another go. And you know, on the whole, it's worked the next time. And it may well be that you just didn't hit it right that time, which is another reason to keep the dose really, really low, because safety is more important than anything else.
And I suppose it's true to say, a bit like saliva diversion surgery or, you know, surgery in general, the Botox similarly, if you have someone that's very, very dystonic or that has very poor posture, it's very difficult to keep all saliva in their mouth, even if you reduce it, I suppose.
Absolutely. So again, I think Dan, that's a very fair point. I think the problem comes is that even if you are reducing the saliva quite markedly, if there's enough saliva there, it'll still come out.
Yeah. Ivan has also asked another couple of questions, Charlie, with regards to SMA, spinal muscular atrophy. I don't know if you have particular experience with regards to those patients. He feels that the Botox seems to be less effective in that group.
Yeah,
and whether you...
fair. I mean, we would have real caution in using botulinum toxin injection. I have done it in some neuromuscular children, but I'm very cautious about going near any of those children with botulinum toxin because I really don't want to make the situation worse. So from my perspective, I really have to be frog marched into a room with the neuromuscular consultant's blessing and a very clear discussion with the families that this is risky. So it's got to be really severe and really problematical before I will go near any neuromuscular child with a needle.
And on the same, well, in a parallel discussion, I know we've also had these discussions about how low can you go in terms of age for Botox, because you've been reluctant in the very young population for slightly different reasons, but it's interesting to see.
I think that's fun. I shudder. I have done it in 1 or 2 18 months. But you know, as somebody with the greatest respect, who's probably done it more than anyone else in Europe, except for maybe the Amsterdam team, there are limits for all of us, and I struggle. I've done 1 or 2 children down at that sort of level if they are on PICU and have been on PICU for a year and you can't get them off a ventilator. But I'm very firm with the parents that this is way outside the norms and agreed evidence base. I mean, the evidence, the set clinical guidance and guidelines say 2 years. Okay, so if you go beyond that, if you go outside that, you are going through your peer-reviewed, agreed process and protocol. So you are setting yourself up for a problem medico-legally. So I am always and document very carefully if I ever go below 2 years that the parents are aware of that and that I'm doing this because I am being requested by them rather than by my own clinical judgment.
Dr. Ali Alami's asked a couple of things. What routes do you use to give glycopyrrolate, and what sort of criteria do you recommend for referral to your tertiary saliva control service so that we send in the correct patients but you're not overwhelmed?
Yeah. Good call. You can give it any form enterally. So they can have it orally. There are tablets out there. Gastrostomy. Hopefully they're not got a nasogastric tube, because if they've got a nasogastric tube, they need to have that changed to a gastrostomy. But, you know, glycopyrronium bromide is pretty easy to get down a gastrostomy tube. When will we recommend referral? When you are uncomfortable with managing it. So we've got some community paediatricians out there in particular who are great, who can manage those early steps of things, and will only refer in when they're considering botulinum. You know, this is not winning. We need to consider botulinum toxin injections. However, there are others in other parts who haven't got a Scooby-Doo what the heck to do, and don't know what an elbow is and don't know what a posterior is, and that's absolutely fine. So it's really dependent upon your own comfort. So we accept referrals from GPs, pediatricians, ENT specialists, and it's really when you need and require a second opinion. So if you think that you've done what you are comfortable with doing, and you've got below and above that situation, and you don't want to be, you know, primarily leading on that from that point, we're happy to take over. We will see anybody, and it's really, we're there as a service to support local teams, and it doesn't matter at what level that their experience and their comfort was, because we're all different.
In terms of, let me just, one more question's come through. Let me just find it. My Zoom.
Frequency of experience of repeated injections.
Yes.
So again, it depends. So I would never do it more often than 3 months. Okay, so again, safety more important. Never do it more often than 3 months. Rarely and occasionally, I'll do it between every 3 to 4 months. And those are children where there are clear clinical challenges associated with their posterior sialorrhoea in particular. So those are children who have frequent aspiration on their secretions, that are at risk of respiratory damage if we don't keep on top of them. And I will do those children every 3 to 4 months. Generally, as I said, on our pro forma, we found on average 6.5859 months it works for. So on the whole, it's once or twice a year that we'll be doing the botulinum toxin injections. Over the years, I've injected every single flaming saliva gland there. So I started off for some unknown reason doing the sublingual glands, and then I moved to submandibular, and then we did both submandibular and both parotid. We have sort of settled on 1 parotid and 2 submandibular because it gives us a good effect whilst minimizing side effect. So we do not see the sort of chew and swallow difficulties if you do a unilateral parotid, and equally you've got enough saliva so that you can have a healthy oromotor cavity if you don't do both parotids, in my sort of experience.
Many thanks for joining up, and have a good rest of the week.